haven't opened Teams in like 2 weeks. So here is a thing for your own reference. This is what is in each of the modules. I hope you know this. If you don't, now you do. The reason I put this in is because a massive question every year is, how much year 4 do I need to know for year 5? And this is what these are the specialties where year 4 there's a bit of overlap. So GP expectably. Dermatology has a lot of overlap with some infections and some rheumatology, but there's a lot of new stuff as well. Coop is basically all of the conditions you learned last year, but in older people. So like when you get around to learning Coop, it's like stroke, Parkinson's, that kind of thing. Like you don't need to learn about every single condition from last year, but like the really big ones that affect older people come up in Coop. Oncology, you kind of just covered last year, so like things like neutropenic sepsis just comes up again. It's like the same kind of thing. And Ophthal has like a fair bit of overlap with rheumatology again. But again, it's only 1 week, so I wouldn't worry too much about it. So if you know like the big things from 4th year, so things like stroke, heart attacks, you're like, that's the kind of stuff that comes up in terms of year 4 overlap with 5th year. We will highlight in these sessions the stuff that does repeat itself. But like in our SBA paper, any of the final years, correct me if I'm wrong, there wasn't very much year 4 stuff at all.
No, and all the year 4 stuff that came up, this is not like a flex. It's not a flex. It's just that I could do it from having done year 4 last year, in the sense that I hadn't had to revise it. It's just sort of questions you can just work out, sort of stuff. But I wouldn't worry about it too much.
Someone just nicked the slides. Let me share them again.
Yeah, I think people try and move the slides along and then by mistake close it.
Yeah, probably. Is that what you've done, Jake? Are you?
No. I wasn't. That wasn't me. That's what I.
Yeah. So yeah, by all means, like keep up to date on like the big stuff in year 4, but like don't stress over it. Is what I'm saying. Fine. So our teaching last year like was pretty simple because like all 3 of the modules in year 4 intersect a lot. Like there's tons and tons and tons of overlap, so we can make like sessions based around all 3 very easily. The issue this year is a bit, so this is what year 5 looks like. So you have these 3 modules which don't really intersect at all, but they all kind of come up in the setting of primary care. So off the bat, like just a heads up, we'll tell you which sessions are going to be relevant to you ahead of time, because we don't want, like, there's no point in you looking at a psychiatry session if you're starting on like module B or module A. Like you can by all means turn up, but like realistically it's not going to be that useful to you, so we'll tell you what's coming.
Can I say quickly though, just with pediatrics, there's a lot of overlap with some of the odd bits in Mod C, like ENT. A lot of that is a few like ear infection and stuff. It's very common in kids. So even if you're doing Mod C at the time, and when we do the pediatrics, we do a lot of stuff on ears and throats and kids. So it's so, like, just because you're doing Mod C, it might be quite useful.
They don't have ENT anymore. They've already done ENT.
Also, since we are
last year. Okay.
Since we are recording all the lectures, even if you are thinking, oh, I don't want to miss peds, when you're doing pediatrics, you can just go back and watch the sessions that were done earlier. So yeah, don't stress too much about it.
So yeah, like already like a few people have messaged me saying like, oh, I'm missing the first session, like what's going on? Like don't worry about it. Everything's recorded. We'll have slides for everything. So because of this, like there's kind of, we basically split it amongst ourselves based on what people liked in 5th year. Cause like, I think no one really likes all of 5th year because it's quite different. So you all know Ahmed, who is currently walking home, I think, from a GP placement, and he's going to do all of the psychiatry stuff. What was that?
I'm walking to the bus stop from the GP placement.
Yeah, final year is busy. You know Jake as well, who's doing peds. We have Jess, who's new and wasn't teaching last year. I don't know whether she's here. Jess, do you want to say hi?
I am here. Can you hear me?
I can hear you.
Yeah, I'm Jess, as Anish said. So I'm doing the women's health lectures. So I really enjoyed obs and gynae last year, particularly obstetrics. So yeah, I'll be doing the women's health lectures this year.
Yeah, and those are going to be great. Me and Ahmed are particularly useless at women's health, so as in we missed our placement.
Because we didn't have it.
Yeah, we're doing obs and gynae at the moment.
We didn't have it.
I'm doing obs and gynae at the moment, so I am still struggling my way through it. And as
and I have to teach each other women's health
from any obs and gynae.
Yeah. I've managed to see a sum total of 3 patients in a week because no one lets me into the room, which is sad. Fine, and then yeah, I'll teach all of the weird medical-y type of things because I like medicine. Cool. What else? Bit of a plan for you to like think about, as in not for you to think about, we thought about. This is what we got based on your feedback last year. We're going to start with like at the start of the year, we'll focus on like basic knowledge and skills. Then in term 2, we'll try and do as much clinical reasoning. So like you figuring out the diagnosis, and then we talk about management from there. And then in term 3, we're going to try and do as many SBAs as possible so you feel prepared for exams. So basically, in term 3 last year, we did the same structure as this, except for we did it all over 1 term. This time, we're going to try to do it over 3 terms. Again, if anyone has any thoughts, message me. I'm very interested to hear them. And I like, here's a quote that I put in, which I think summarizes 5th year quite well. Does anyone know what this means from 4th year? Sorry, I like trivia. Pub quizzes are my thing. Yeah, it's just a fancy way of saying common things are common. And with 5th year, right, all of the specialties are massive. And if you spent enough time and if you're interested in them, you could read into like an incredible amount of depth into all of the specialties that you do in 5th year. The fact is, the medical school will highlight what conditions are important. They'll tell you where you should guide they'll guide your own learning. So try not to get caught up in details. Try and look at like the main conditions that they'll highlight in teaching. Like, I think a good example would be ophthalmology. Like, it's like one of the most intricate specialties. It's 1 week. You could spend ages on it, but like only 5 conditions really ever come up in exams. So common things are common. Don't spend, this year especially, don't spend too long on like niche things. I don't know if anyone else has any comments on that. Nope, in agreement. Cool. And then, yeah, this is basically what I said. Your teaching should highlight the core conditions. And like, I don't mean the core conditions on the curriculum map, because even on the curriculum map, there are some conditions that are not going to come up or aren't that likely to come up. So have a look at, if you don't go to med school teaching, like I'm not saying that all med school teaching is good, but it's often worth glancing through some slides just to see what they're trying to focus on. Fine. Right, that's it for intro stuff. Basically, don't get bogged down in details. Look at what the med school's emphasizing. If you have questions, actually, let's stop for 5 minutes. If anyone has any questions about 5th year, we can ask them now before we go on to this. If there's no questions, we'll start, but yeah. Also, yeah, if you're not on one of these 3 things, you can stay, but it is recorded. So feel free to leave. But if you are on one of these 3 things, this is relevant to you. Quick question on resources. Did you use textbooks for specialties? I know Ahmed didn't.
I didn't.
I know Jake didn't. I found a couple of good textbooks. So for pediatrics, there's a textbook called Crash Course Pediatrics that's really concise. that I really liked. That's what my consultant recommended me, and he's like, you definitely don't need anything more detailed than that.
Yeah, my flatmate could endorse that text. My flatmate can endorse that text as well. That's how we did his entirety of PEDS. It's a really good textbook, apparently.
Yeah,
I think there's an obs and gynae equivalent too. Possibly.
Yeah, I didn't so much use it. And then for obs and gynae, I used bits of essentials of Kumar and Clark for like the physiology of pregnancy, but honestly, that doesn't come up so much. I don't know. I think you could probably get away. Jess, do you have anything you'd recommend for obs and gynae?
I predominantly use the BMJ. I hate textbooks because they're so thick and there's loads of information. So I predominantly use the BMJ because it lays out every condition, how you need it, and like the diagnosis, the investigations, the management, the treatment. And I find that really useful. So that's predominantly what I used. And then sometimes the nice guidelines, but they're quite heavy. But I predominantly use the BMJ.
Yeah.
I discovered Teach Me Obs and Gynae, which is the people behind Teach Me Anatomy. They've made very much a similar, very interactive summary for Obs and Gynae, which I found very, very useful towards the end when I've sort of gone through my stuff and I was like, I want to go over some things quite quickly. So I found that very, very useful. Also, like a quick summary issue. It's a really, it's if you don't like textbooks like Jess said, which are like content heavy, this one slims it all down, bullet points, and then there's like 5 or 6 questions at the end of each page to test if you actually understood it, and then you can highlight stuff you didn't know. So I would recommend that one. It's just Teach Me Obs and Gynae. It will come up. It's a good one.
Two other resources I think quite good to mention. One is patient.co.uk. It's a website which is really quite, there's a section of it for professionals, and the reason I think it's quite useful is because also there's the same pages but from a patient perspective. So because communication skills are a really big part of 5th year when it comes to the OSCEs because of GP, it's good to sort of be able to have looking at the professional side for your actual learning purposes, but also the patient side is good for when it comes to OSCEs and explaining conditions. The other thing is, as Anush will thoroughly agree, 5th year is very heavily guideline based. Nice CKS, the clinical knowledge summaries are your friends here. Like that was probably one of the few things I used because actually they get asked, questions get asked based on those. So check out patient.co.uk, and 5th year is very guideline heavy.
5th year, I forgot to put a slide in about this, but 5th year is just so many guidelines and it's just intensely upsetting. But
enjoy.
There's a few, a lot of the things are just purely guideline based. A lot of dermatology, a lot of peds. A lot of GP is referrals, so you need to look at guidelines, unfortunately. I will also say you can't use NICE for obs and gynae. You need to use the Royal College. They have better guidelines. So use those for obs and gynae. What about the Oxford Handbook of Clinical Specialties? I'm going to be super honest here. I have the PDF of it if anyone wants it. I didn't touch it once in the entire year because it's super detailed and it has loads of information in it. I don't know if anyone else used it.
I'm going to assume that if people liked the Handbook of Clinical Medicine and used it a lot last year, they'll probably appreciate the Handbook of Clinical Specialties. Basically, stick to what works for you. If clinical medicine worked last year, then I think you'll appreciate the handbook. If you didn't, then don't start something new.
Yeah. The only thing I will say with the handbook this year is it has stuff that you that is beyond your level of knowledge, definitely. So if you're going to use it, have a look at the curriculum map before you go on making notes into some really detailed pediatric diagnoses, because you don't want to waste your time, right? But so if you basically if you found something that works for you last time, don't change it. Management section of BMJ is based on guidelines. It's freaking BMJ best practice is amazing. If you haven't used it last year. Anything else? Okay. What are the question banks like for specialties. Is PassMed good for 5th year? Is PassMed? Yeah, I haven't talked about it. Thoughts on PassMed for 5th year?
I think it's very similar.
I'd say similar to 4th year. It's good for information acquisition. The level of difficulty isn't the same, obviously, but for getting like the bare level of information, like that's what I used to learn the things which we missed last year. I got that information from PassMed, so same as 4th year. It's good for learning information, but not good for
do it as you go along.
Yeah.
Do it as you go along. So other question banks. So I think between us we might have used all of them.
I think we used all of them. Pass test.
So
pass test. I love pass test.
Pass test is pretty good as well. It's very PassMed like, but it's a bit more challenging.
Yeah.
It's cheap. It's super freaking cheap. Super cheap. What else? Oh, assess and progress is surprisingly easy for clinical specialties.
Yeah,
like
it's weird.
It's not representative of the exam at all.
I also used QuizMed.
Sorry. Okay.
I used QuizMed. There's not very many questions. It's probably about half the size of PassMed, but it's good in the fact it covers different stuff to PassMed. So if you've done PassMed and you want to look at something else, it covers. It's not. I mean, some of it was a little bit more difficult, and I'd say generally on the whole it is more difficult. But it covers different things to PassMed. So in that sense, it was useful if you wanted to like go over more topics.
If you have time, do QuizMed basically.
Yeah, QuizMed isn't like last year you might have noticed that there was a lot of niche stuff. For 5th year there isn't that much niche stuff in QuizMed. It's just slightly harder stuff.
Yeah.
It
repeats a lot of questions, which is one issue I have with it. But it's closer to UCL difficulty. So
yeah.
Mainly because most of the questions are UCL questions that were stolen from summatives.
If you still have access to Capsule, it was really good.
Yeah, that was surprisingly useful.
Yeah, it's really good for learning. It's not good for practicing.
I presume we still do have it. I think UCL got it. I think we still have it.
Also, I will use this as you will probably see less patients this year than you were meant to. So you got sent a link to something called Speaking Clinically, where patients talk about their conditions. And I think this year that might come in quite handy, especially if you're struggling to see patients like yours truly. I would recommend using that as well. That's not a question bank, it's just patient interviews. Anything else about year 5? As in, basically, it's similar to 4th year. You put in the work, and it'll be fine. I think that's. I'm assuming there's no other questions.
Not seeing anything.
I am not. Right. So, yeah. If you're not on Mod A or you're not starting on Obs and Gynae, you can head off or you can stay. It's up to you. I assume Ahmed is going to get on his bus.
I'm on my bus.
Oh, you're on your bus. Excellent. So we'll make a start on newborn baby check. If you have any other questions, just message in the chat or message any of us and we'll reply. So here's a really detailed website on the newborn baby check. Oh, wait 1 second, one last question. Are there any good year 5 notes? I don't know. I don't use any and I haven't been given access to any. I don't know if anyone else knows.
I didn't really use. What do you mean, like past people's notes? I presume.
Yeah, I didn't really use any.
I didn't hear anyone like in year 4 like a go-to notes. I think some people did, but I didn't personally. I did more of the question bank route this year.
Yeah. We'll let you know. We'll ask around. You can ask some of your final year friends. But yeah, I don't really use other people's notes. Anush has trust issues. Sorry, that was a useless answer. But yeah, I can try and find out. What about CPP for this year? So CPP for year 5. CPP for year 5 is basically super similar to CPP for year 4. There isn't like a lot of new stuff. There's like all of year 5 is pretty CPP heavy in that you're looking after patients. So you learned about medicine in the general population in 4th year. In year 5, you're learning about conditions in people in sometimes marginalized communities, or with extra like changes in physiology and stuff going on. So in obstetrics, you're looking after people who are pregnant. In gum and HIV, you're looking after people who have lots and lots of interactions because they're on medication for HIV. Like a lot of these situations are quite sensitive. So like a lot of year 5 is soft skills and working on your communication so that you can make patients feel welcome and comfortable with you as a clinician. So CPP is less of like a specific thing, but more of just a running theme throughout the year, if that makes sense.
In terms of the few specific things, Nish, carry on.
I was just going to go on to the specifics, but yeah, go for it.
Yeah, so specific things are fairly specialty related. So it's pediatrics, safeguarding, obs and gynae, FGM and domestic abuse, contraception and abortion are the main ones. And then you've got psychiatry, which has got your mental health act side of things, and you've got deprivation of liberty in care of the elderly. Those are your hard topics. Otherwise, like Anush said, most of it is, your soft skills. Oh, and GP's got migrants and refugees as well. So that's the other one.
GP has like a ton of nonsense that you won't even think of aside from that as well. And we'll try and put up a list at some point. GP has so much random stuff, like it will blow your mind, like what they ask you questions on. Like there's stuff about like public health, economics. There's economics stuff in GP. It's honestly bizarre. But yeah, we'll try and we'll have a look through and try and come up with a list. Any good resources for psych?
Ahmed.
I'll answer that in the chat.
Ahmed,
just
good
so
resource for
Jake
psych.
started. I'll answer that in the chat just so you guys can get started.
Cool. So newborn baby check. What you will be able to do if you want to know how to do a top to tail examination of a newborn, you should check out this link. The only way you're really going to learn how to do this is by doing it in real life and getting a pediatrician to kind of like show you. What we're going to try and do is justify why we do each thing in the baby check and what kind of pathologies you can pick up during a newborn baby check. So if we split it into 3 big things: why, when, and where. So why do you think we check a baby within like when they're born? What's the most important thing we're looking for? You can answer in the chat. So, yeah, so congenital defects are a big thing. We basically want to find out if they were born with any kind of abnormality or something that needs support. And like the reason for that is pretty much you want to get them like an early referral. So lots of things are much easier to correct at a young age than they are later if you delay it. So the important thing is you're screening for these abnormalities early on. Does anyone know when you do the baby check in terms of time frame? So you actually do it. So the first time you do it within 72 hours, and then you're going to follow up. So, well, you're not going to follow up, but the GP is going to follow up, and they're going to do it 6 to 8 weeks. And And yeah, you do it initially in a hospital, and then you're going to do the second check at the GP. So that's like the basic premise of the baby check. And what kind of stuff? So before you actually examine the baby, what kind of things would you do before you actually hold the baby? So even before you inspect. So yeah, inspection is obviously is the first step in any examination, which is great. So yeah, you set up the space and you gather equipment. What else? Before you even meet the baby, so even before that, yeah, you get permission from parents and you want to try and get them involved. So also don't forget, you need a history. So you're going to get permission from the parents and you're going to take a history from the parents. And you're also going to do measurements. So get permission, take a history, do measurements. What measurements do you want to do on a baby initially? So head circumference, weight, and what's the last one? Height, length, whatever, it depends on the dimension. So these are the things you're going to do before you even like examine the baby. Fine. So head to toe is the easiest way to examine a baby. Inspection is still the most important part. So do you want to tell us what? So what's the top left? The chat has just gone. Jake can answer these.
Okay, so premature baby.
Yeah, exactly.
With that one.
1 second. What history are you taking? Is it? Yeah, exactly. So sorry, I should have specified. The history you're taking was it a normal labor? Was it a C-section? You want to take a bit of an obstetric history. We'll cover it another time. But yeah, it's an obstetric history. Sorry, continue.
So bottom left. Anyone know what bottom left is? Yeah, we're going to get onto that in a second. And then on the right, yeah, slightly blue, isn't it? So cyanose. So these are all the things that they will be looking out for, like small little signs, but they're very, very important.
So with the premature baby, a really important sign is the skin. So often the skin isn't keratinized yet, which is why it's so red and it's almost like translucent. Fine. Here's a big take-home message. Jaundice under 24 hours is always pathological. So jaundice in babies can sometimes be physiological, but if it's within the first 24 hours, something's wrong. So we're still inspecting. Any idea what this is?
Kudos if you know what this is.
Yeah, this is hard. So club wrist. That's a creative thought, but it's not.
Yes, herbs palsy.
This is good. Yeah. And why could a baby be born with herbs palsy? What kind of thing? So for those of you starting on obstetrics, oh, perfect. Yeah. So a baby who has a shoulder dystocia, so when they get stuck during delivery, might end up with something like an herbs palsy.
Which type of mothers are more at risk of delivering babies with shoulder dystocia? I'm not sure that's the right way of saying it, but what condition may they have? Yeah, and why? I know this is labouring the point, but it's very common, and the reason why these patients exactly. So, but diabetic patients, it's I'm sure Jess will go into this more detail, but I think they try and ask the baby to be delivered by a certain date because they're worried about this exact thing. Also about the fact their lungs aren't maturing as well as they should be. So they sometimes even offer cesarean section as a first come rather than going vaginal. Obviously, it's mother's choice, unless there's a certain types, which we'll go into not now, but this is a huge risk factor for macrosomic babies, and we'll go over this later at a later date.
Basically, in diabetic mothers, insulin acts like as IGF-1. So because there's insulin resistance, IGF-1 goes up, so the babies grow. Some physiology that you don't need to know, and it won't come up in exams, but I like figuring it out.
Yeah, I like it. It's interesting.
Yeah. Good. So this is the overlap between obs and gynae and peds. Really, you need to think about how the baby's been delivered. So really big babies.
Really quickly. Does anyone know why they have this palsy? What's been damaged? As in, like what has been damaged to cause this deformity? A bit of year anatomy. Year 2. Yes, exactly.
Yeah, so, upper trunks. Yep, C5, C6. So people on obs and gynae go and shoulder dystocia is a huge thing, and it's something like that's like a core thing you should read up on, maybe this week or something if you're starting on obs and gynae. So yeah, just a quick like medicine thing. So upper 2 things, C5, C6, you get an Erb's palsy. And then lower 3 roots, you get a Klumpke's palsy. They're slightly different. You don't tend to get Klumpke's with shoulder dystocia. It tends to be another cause, but it can still happen. Okay, and then so after you've done like your general inspection, you're going to check the tone of the baby. So what are you looking for in particular when you're checking the tone of a baby? Does anyone know? It's okay if you don't. This is your first week. I knew nothing about this during.
Can you see the chat, Anush? I can see it. Can you see it?
I can see. I have it open on my phone.
Cool.
This is my only solution. Have some.
What would you be worried about if you saw a baby? And with regards to their tone, what were we worrying?
Yeah, let's pretend you don't know any medicine.
Which to be honest, I didn't. Still don't.
Yeah, I mean, my knowledge is questionable at times. So the big thing we're worried about really is it a really floppy baby? So a floppy baby is generally worrying because that suggests that they're not very well. And you can split up the causes of a floppy baby into problems with the neurology or the muscular element, or they can have genetic syndromes. So can you think of any congenital neuromuscular problems that might cause a baby to be a bit floppy? If you're on PEDS, you definitely had a lecture on one of these last week. Oh, look, Anush knows what lectures people have had.
Yeah, impressive.
So what neurological problems can kids get when they're being born? Right, I'll give you a clue. So let's say that they've had like cerebral palsy. If they've had a prolonged labor and they've not been able to get the baby out quickly, babies can become hypoxic, and then that that nature causes ischemia to parts of the brain, and they get cerebral palsy. Cerebral palsy, to simplify, is basically a stroke in the developing brain, and that's one of the causes of a neuromuscular problem. Another problem is like congenital problems like muscular dystrophies that can just prevent the muscles from working properly. And then a thing in PEDS that people learn a lot about but doesn't come up that often is the genetic syndromes. So things like Down syndrome and Prader-Willi can cause a floppy baby. Down syndrome is a huge exam topic. The other genetic syndromes come up significantly less frequently, but Down syndrome is something you need to basically know like the back of your hand. So yeah, if you start on PEDS, have a read about Down syndrome at some point this week, I would say. Fine. Does anyone know what's happening in this photo? This is basically just a spot the diagnosis sign. So this is microcephaly, which Zika virus is a cause, is not a common cause, but is a cause. So good. So microcephaly is basically a smaller head than normal. And then you can split up causes of microcephaly once again into maternal infections, genetic syndromes, and maternal toxins. So we can go through each of these. So one maternal infection that causes microcephaly is Zika. Anyone know any others? So what other infections happen during like the antenatal period that you might cause a tiny thing? What's the difference between microcephaly and anencephaly? So anencephaly is a problem with the top part of your spinal cord in terms of developmental origin. It fails to close. Microcephaly is just a small head. It's not like a neural crest development. It's not like an embryological problem. Toxoplasmosis is very common. It's carried by cats. Yeah, that's definitely a cause. Rubella and chickenpox are the other big causes. Genetic syndromes, I'm not going to ask you for because honestly, there's no way of figuring out what genetic syndrome causes what. There's no like kind of reasoning I can give you. They just do because they screw up a lot of things.
Also, past med is very heavy on genetic syndromes in peds, and I think that could make you think they're very, very important to learn in detail. The only one, as you said, important to learn in a lot of detail is Down syndrome. And I think that the Edwards and Bateau, good to know, not that useful, will get you a mark at most, and not that helpful than anything else. But Downs has a lot of overlap with other conditions as well, so it's important.
Down syndrome is probably the single biggest topic in pediatrics because it has so much overlap with other things. And then maternal toxins. So does anyone know what kind of toxins can cause microcephaly? There's a really, really important one.
Ahmed's missing an absolute essay here. That's very good.
Yeah, Ahmed loves psych, in case you guys didn't know.
He's very good at it as well.
Alcohol, absolutely nice. The most, like, anyone who becomes pregnant is immediately advised to not drink any more alcohol because it's really bad for the child.
Also, if you guys can see, I mean, once you've had a good idea of pediatrics and obs and gynae, you'll realize that there is a sort of trend to some of the things. So the whole idea of when you're being developing is that your brain wants to conserve as much energy as possible, like it does when you're born. So malnutrition, when people talk about when they bring small babies, those babies tend to have big heads and small bodies because they had later on in development they had these problems with malnutrition. But all these things they happen early on in development. For example, Torch and Edwards and Pato, and if they're drinking from the start, they're probably going to be drinking when they first get pregnant. So these sort of things, when you saw a baby with microcephaly, tend to think that these problems probably happened before or happened as soon as the baby was beginning development, not towards the end.
The head develops very early, basically. And when you're on obs and gynae, you'll come across the Torch infections that Jake just told you about, and these are like the key infections that go on to cause problems to the fetus. For your reference, these are toxoplasmosis.
I'll write them in.
He's writing them in the chat. So those are the infections you should know about for obs and gynae and for peds. Fine. Here's another head. Oh, there's a lot of heads, sorry. Does anyone know what's going on here? You can interrupt Jake's messages, it's okay.
Sorry, I don't know why it won't let me do it. I have to do one at a time. This is the ones I have at the top of my head. I'll write down a proper list, but these are the ones I have in here.
Those are the really important ones, the ones he's just...
and also the reason they're called Torch is not that's the way I remember it, but the reason they're all grouped together is more specifically that they cross over the placenta and affect the baby during development. So you have other things, infections that when you're pregnant you can get, but those don't tend to cause such bad effects because they can't cross the placenta. So these are the ones that cross, and rubella, CMV, HIV, toxoplasmosis. We all talk about these because they are very tested, and also spotting them is important.
They also all cause really similar developmental issues. Like, there's lots of overlap. It's super annoying in exams.
Yeah, but there are a few key words I'd like to throw out. But yeah, I'm also going to need to head off. Sorry, guys. I have to go and pretend to play football. But I will see you all very soon, and looking forward to it.
Yeah. We will be done in like 15 minutes or so, despite the fact that I have a ton of slides. So this picture is a normal head, actually. So this is what happens when you have a delayed labor. So if the head's stuck in the canal for a long time, it tends to be oblong. This will sort itself out. So you don't really need to worry about this. This is another important thing. Does anyone know what's going on here? Again, like first week, you don't need to know. But like if you do, good on you. So is this baby's head normal or abnormal? Is this what heads normally look like? There is a lump. Yes, this is not what heads normally look like. Abnormal. So what's gone on here is you've all covered intracranial hemorrhages last year. So like subdural, extradural, subarachnoid. This year in peds, they get like during birth, they get extracranial bleeds. So they can get blood pooling in different parts of the scalp. And the ones that come up, this is nicked straight from PassMed, are this thing called caput succedaneum, I can't even pronounce it, encephalohematoma. And the important distinguishing factor is the fact that one does cross the suture lines and one doesn't. And if you look in this diagram, you can see that because of the layer within the layers they are, that's why one of them does cross and the other one doesn't. Both of them are managed conservatively. They're not really that dangerous. This slide is everything you need to know about them. Fine. So what are these? So this is something you should know, I hope. What are these openings in the skull called? Fontanelles, yes. So this is where the different bones that make up your skull haven't yet fused, and it allows for the head to. You basically need the sutures and the fontanelles because as you deliver a child, the canal is very small and everything kind of squishes together. Fontanelles are super useful in pediatrics. So in an adult, when we're worried about the fluid status, we need to do a complex examination. We have to look at their JVP. We have to look at their legs. We have to listen to their heart. It's a pain. In babies, fontanelles can either be bulging or sunken. If they're bulging, there's probably some cause of raised ICP, which is concerning in kids because it could be some kind of congenital tumor. And if it's sunken, it means that they're dehydrated. This is a super cheat way of figuring out fluid status for kids, but kids are often dehydrated because they throw up a lot. Unfortunately, as soon as the fontanelles close, you can't look at them anymore, which is kind of sad. Face, very important. So here's a few things that you can look for in the face. Does anyone know what the left image is? So this is a super subtle image. Yeah, so the left image is Down syndrome. So you've got the upslanting palpebral fissures, you've got the slightly wide set eyes, the round face. Again, I've mentioned Down syndrome 5 times maybe this lecture already, and that's how much it comes up. Does anyone know what the middle picture is? And if you don't know what it is, do you think this is dangerous or a minor thing? So even if you don't know what it is. So yeah, this is like an infant hemangioma, and these tend to resolve in a few months. They're not a problem at all. And then one of my favorite clinical signs. Does anyone know what the thing on the right is? And for a bonus point, yes, it's a port wine stain. Which famous politician has a port wine stain? So port wine stains generally pretty benign, but in a number of people, they form part of a systemic condition called Sturge-Weber syndrome, which means it's basically an AV malformation in the skin. So if they have one here, you kind of need to scan the brain as well, because they might have one inside the brain, which can bleed and cause problems in the future. But yeah, usually they're pretty benign. The politician was Gorbachev, the last premier of the Soviet Union. He was known for his port wine stain. Fine, face done. And then there's the stuff near the face. So you're going to look at the eyes. We'll talk about the red reflex at the end because it's important. You look for red eyes. You might look for jaundice. Why might a newborn baby have red eyes? So let me remind you that everywhere in the body has commensal bacteria. So why might a newborn baby have red eyes? Not ophthalmitis, but just conjunctivitis. So as it's being delivered, they can get infections from the commensals of the vaginal tract. So the conjunctivitis neonatorum, I think it's called, is where they get a really early conjunctivitis. So that's important to know. You're just looking for asymmetry or low airs. They might be a sign of a congenital problem. Mouth, important. You can get a cleft palate, you can get a cleft lip, or you can get a tongue tie. I haven't put images of a tongue tie, but these are important as they can stop them feeding in like the early part of their life. So what's this? Cleft lip and cleft palate specifically. This baby has both because it goes further back. And there's a lot of causes of these. I'm not going to go into them today, but we can talk about it another time. What's this? While you're onto that, just when you're examining a baby, so babies cry a lot. Super easy thing. If you put your thumb in the baby's mouth, it automatically suckles. While you're doing that, you can check for a cleft palate. So if the baby starts crying, just let it suckle on your thumb. And while you're doing that, check for any kind of cleft within its palate. Causes of a web neck. Turner syndrome is the most important cause. What if I told you that this person was male? There is one other syndrome that causes a web neck. Yeah, it's okay if you don't know it again. So if it's a female, Turner syndrome, you definitely want to think about. And Turner syndrome is fairly important because it comes up in gynae as well, because they can get primary amenorrhea. But yeah, from a pediatric perspective, it comes up as well. The other thing is Noonan syndrome. So if it's a male with a web neck, you want to think about Noonan syndrome. I don't know much else about it, to be honest. What other problems do people with Turner syndrome get from fourth year? So we've talked about primary amenorrhea, and we've talked about web neck. There's one other big cardiology thing that they get. Poor fertility, short stature is is the phenotype. Yeah. Good. What about cardiac problems? Pediatric cardiology is something that they love to ask you about. So yeah, they get coarctation of the aorta. So on a related note, we'll move on to examining the chest. You do your chest exam as you do it in an adult. The only extra things you do is murmurs are way more important in pediatrics than they are in adults. So like you always auscultate for murmurs in adults, but like in kids, they're like make or break. So try and listen to as many kids like hearts, because the pulse is really fast, which makes them hard to pick up. Like they probably won't ask you to do it in an exam, but if you're interested in pediatrics or you might have a pediatric job, it's important that you can pick up murmurs. And then also the signs of respiratory distress, and there's like a 4-step approach in terms of how bad the respiratory distress is, and we'll talk about that when we cover asthma or bronchiolitis. And then you also get these chest wall abnormalities. So do you know what? So which one is which? Pectus carinatum and pectus excavatum. Yeah, so carinatum is where the sternum sticks out. Excavatum is where it goes in. Both of these can cause problems with their breathing, if severe, if mild, not so much. There you go. And then this is something that they love to test. This comes up all the time. Features of an innocent murmur versus features of a concerning murmur that might highlight some pathology. So, oops, I showed you. So if it varies with posture, it's innocent. Because that suggests that it's just because the baby's small and you can hear like the blood flowing against the heart. You can guess the rest. Diastolic murmurs, innocent or concerning. There's like 4 of these, and they're all super important. So if you had a diastolic murmur, would you refer to cardiology, or would you be like, you can go home? Absolutely refer. So same as in an adult, like diastolic murmurs are always pathological. For a diastolic murmur to be heard, that means that there has to be some significant structural issue, because systolic murmurs are always more common. You notice that there is no thrill. What are you going to do? Refer or just discharge? Thrills is... I'll tell you something else in a minute. What are you going to do? There's no thrill. Yeah, innocent. Thrills are actually very common in kids. So kids with like underlying pathology will have thrills. So if you went through all of 4th year having not felt a thrill, it is your time to feel a thrill in pediatrics. And then there is radiation of the murmur to a specific part. Are you concerned, or are you going to discharge? Innocent or concerning, whatever you want to say. So yeah, if it's radiating, it's concerning, because that means there's a specific pattern to it, which means there's a structural problem. So these 4 things come up a lot. So know these 4 things about whether, and like if you have any pediatric cardiology teaching, they're going to ask you about these 4 things. Very popular topic in year 5. Strong association with Down syndrome. You can split it into cyanotic and acyanotic. We'll cover these later in detail and why they're called these. But acyanotic lesions are things like septal defects, patent ductus arteriosus, and coarctation of the aorta, which we talked about in relation to Turner's. And then cyanotic, the 2 big ones are tetralogy of Fallot, which you may or may not have read about last year, and transposition of the great arteries, where there is literally a switch between the vena cava and the aorta. It's like the craziest thing. We will cover these in detail because they love to ask about them. Abdomen, again, you do your examination as normal. In a newborn, you tend to just use one hand. And yet again, if you didn't feel a liver all of last year, it is your time to feel a liver. You can usually feel a liver in kids because they're slightly bigger than the ribs, so they'll go further below. These are the specific things you want to look for in kids. Any umbilical pathology, because they've recently had a cord. They might have a hernia near that. You need to check whether the genitals are normal and check if the anus is perforate. We'll talk about meconium passage. Don't worry about it for now. Limbs. Oh, this was meant to be animated, but I clearly forgot. Remember to check all of the pulses in kids. If they've got like variation between the radial pulses, you're going to be worried that they've got coarctation. If they've got an absent femoral, you're going to be worried about coarctation. It's not that rare, so you should always check. And then you're going to look for extra digits, asymmetry, or deformities. Hopefully, you won't need to think about the last 3 because they're pretty natural. Like you would notice it if there was something there. Does anyone know what's going on here? So this is a pretty subtle sign. So if you're confused, look at your own hand and tell me what's different. Palmar creases, yes. What about palmar crease? What about it? There's a specific thing about it. Yeah, there's a missing palmar crease. So basically, there's a horizontal single palmar crease in this case, and that often goes along with chromosomal abnormalities, like yet again Down syndrome. So I think that's the 7th time I've mentioned Down syndrome. So I hope you've got the point about how much it comes up. So alongside the limbs, you want to test the hips. So what important condition do kids sometimes get in relation to their hips that you might have seen in orthopedics? And what are the 2 tests for it? Yeah, so development dysplasia of the hip is a very, very important condition. And there's 2 tests that you can do in the clinical environment for that. Ortolani's and Barlow's, absolutely. So Barlow's is where you add, I've got diagrams, you adduct the hip and you're trying to displace it. Ortolani's, you're trying to abduct the hip and replace it from being displaced. Here is a great comic that I found. You do just need to learn those 2 tests. Hopefully you'll get the chance to practice on a real baby. If not, they have dolls around, so ask if you can at least practice on those. But yeah, and if someone gets a positive test, what would you do next? Does anyone know? So you're worried about dysplasia, you've done these tests, and you're still worried that they have developmental dysplasia. Do you know what the first line investigation is? So management is you can use braces in an abducted position. Yeah, but before you manage them, you want to confirm your diagnosis. This has good sensitivity, but isn't that specific. Absolutely, you're going to ultrasound the hips, and that will show you whether or not they do truly have a dysplasia. But yeah, then you can do conservative management within the first few months, or they might need surgery later on in life. And then we're almost at the end. The back. These are 3 things that you can find on the back. So let's start on the left. Does anyone know what this is? So what does it look like? It doesn't matter what it is. What does it just look like if you're going to describe it? It looks like a tuft of hair. So does anyone know what a tuft of hair on the back in that distribution is a sign of? Yeah, so this is a neural tube defect. So this is spina bifida occulta, which means there's not a true opening, but there is a tuft of hair suggesting there is an abnormality. And then the middle thing is true spina bifida, where the contents of the neural tube, or rather the derivatives of the neural tube, have come out of the skin. So the middle thing is spina bifida. Does anyone know what's on the right? So on the right is a Mongolian blue spot, which you just need to document in the notes. It's not a Sjogren patch, but that's a good thought. We'll go over some of those conditions another day, but yeah. So this is a Mongolian blue spot. It's completely normal and very common. You just document it in the notes. So what do you give people trying to conceive and have a baby in order to prevent spina bifida? What drug do we give them? Folic acid, yeah. So, and the doses you might want to make a note of. So if they haven't got any major risk factors, like they're not on anti-epileptics or anything like that, you're going to give them 400 micrograms. And if they do have some of the risk factors, you're going to give them a higher dose. I think it's usually like 5 milligrams, so it's a significantly higher dose. So just a useful thing that you need to give mothers when they're trying to conceive. Fine. Reflexes are the last bit of your exam. You need to do the red reflex, the Murmur reflex, you realistically you'll have done the suckling reflex because the baby will have started to cry when you press its abdomen. So hopefully you've done that already, and the palmar grasp. So red reflex is where you take an ophthalmoscope that you will hopefully use in ophthalmology, and you just look at the eye from around 50 centimeters away. And if you can see the retina and it looks red, that's a normal red reflex. If you can't see the retina, it's called anisocoria, and that suggests that there's some kind of blockage between the retina and your eye. So somewhere within the eye, there is some kind of blockage. And that's what the bottom right is, what that looks like. It might be absent, or you might have like a bright white color. So it can present both ways. And the causes of an absent red reflex you can figure out based on the fact that you know it's some kind of blockage. So what kind of blockages occur in the eye? What could be blocking our view of the retina in a kid? When in doubt, you can always refer back to the surgical sieve, because it will give you at least one of these answers. So yeah, so it could be a malignant tumor. It could be like a retinoblastoma. Yeah. What's it called when our lens crystallizes and you can't see through it anymore? Cataract. So kids can get congenital cataracts. So those are the two important ones that you might have heard of. So congenital cataracts, a couple of ophthalmology things, and retinoblastoma. We'll talk about ophthalmology another day because it's quite simple, but it's not taught well, so everyone thinks it's really hard. So this is the Murmur reflex. You can go and wait. You can watch this in your own time. Effectively, when you drop a baby, it sticks its arms out. And a baby that is developing correctly will stick its arms out as you drop it. You don't actually drop the baby. Watch this video. It will show you how to do it properly. But if it doesn't stick its arms out, it's not such a good thing. And then palmar grasp is the fact that if you put your finger in the palm of a baby, it will naturally grasp it. If it doesn't do that, you might be worried about some kind of a similar thing to like the floppy babies. You might be worried about some neurological issue. Remember that like some of these might not be the case in a premature baby, because premature babies haven't fully finished developing. Often you won't be able to examine them either because they're super gentle. So you'll wait until they become the same age as a term baby. Fine. That's the end. So those are some of the things you can find on the examination. So if you have any questions, ask them. Can you just fill out feedback? So like last year, I'm collecting feedback after every session. So it's like we can change the format. If you don't find it useful, we can try and make it more useful. So I'm super interested to hear what you have to say. Also, if you don't like filling out feedback and you have like specific stuff you want to tell me, just message me. That's fine. Just a heads up, I will not be teaching most of like anything else because I'm not very good at 50th stuff. So it'll be the others, but I will read all your feedback, I promise. Yeah, no worries. We'll also stick to this time for now, but we'll change it. If you put that in the feedback and it doesn't work, we can change that as well. We can basically do whatever. I'm going to stop recording there for now.